Okay, so test-taking strategies. Again, it's a little bit of a review from what I did in Nursing 110 for you guys, but it is, I'm going to give you a lot more practice questions, and some of the examples that I'm giving are a little bit more difficult because, you know, you're farther along in the program than what you were. Critical thinking, have you heard that word enough? Validating and organizing data, looking for patterns and relationships, and then transferring that knowledge from one situation to the other. Again, we cannot teach you every disease, every medication, everything that you need to know for your clinical practice or to pass the NCLEX. So you have to be able to take the core knowledge that we've given you, the basic stuff, the stuff that you already know, and put it into those situations, because many of your NCLEX questions are going to involve a scenario. And if you don't have that core knowledge to know what's the normal ABGs, what's the normal electrolytes, a lot of different things that are going to go into that core knowledge, you're not going to be able to apply that to answer your question and maybe get you know, transferred down to a different path from where you were supposed to go. So your first strategy is don't read beyond the circumstances. Now I know some of you work as an LPN, some people work as CNAs. You've had a lot of clinical experience by now, so you've seen things being done correctly, maybe incorrectly. Could someone shut the door, please? What you have to do is take your personal experiences, be they work experiences or clinical from in nursing school or your own personal life experiences or families, take them out of the equation. Take the what-ifs out of the equation when you're reading an NCLEX question. Read every single word in the question, but don't read into the question. Don't say, okay, I've got this set of facts, but what if this or what if that, to kind of complicate measures. Read every word, focus on where that question is trying to lead you. Because how many of you seen on most of your exam questions now, you get it down to those two really good answers, and it's really hard to figure out which one is the best. Many of your NCLEX questions will be 4 correct answers, but one of them is going to be the best. People are coming back to me after taking the NCLEX, and they're saying that the majority of the questions that they're getting are prioritization. What's the first thing you're going to do? What's the best response? Delegation. Who's the appropriate person to give this particular patient to versus this patient? And the ever popular select all that apply. And I do have a strategy for select all that apply. So don't read beyond the circumstances. Look for the keywords that are going to tell you specifically what that question is asking you. So pick up your clickers. The client with metastatic cancer is receiving a continuous IV infusion of morphine to alleviate pain. Select the adverse effect or sign of toxicity for which the nurse monitors the client. Dizziness, sedation, skeletal muscle flaccidity, nausea. Okay, so nobody picked dizziness, 26% picked sedation, 70% skeletal muscle flaccidity, 4% picked nausea. What are the key words in this question? Adverse effect and sign of toxicity. So what that's telling you is to steer away from expected side effects of morphine and key in on the one you wouldn't expect to see. So would you expect dizziness in a patient with morphine? Sure. You know, and sedation, sure. You know, if you've ever seen anybody get morphine, I've sat there and pushed morphine over 5 minutes and talking to the patient, and you know, the eyes roll back, and you know, before the 5 minutes are over, they're sleeping. Nausea, oftentimes with opioid analgesics, but you're not going to see skeletal muscle flaccidity And it's kind of a key thing. If you ever pick up an NCLEX question, they talk about somebody being floppy and lethargic, and that's not a good thing. That's a kind of a red flag. Skeletal muscle flaccidity, another red flag. So that's an adverse effect, a sign of toxicity, not an expected side effect. Strategy 2, look for those keywords. Now keywords like early, late, best, most appropriate, least appropriate. Again, they're asking you to prioritize. So you want to see where it is that they're, what specifics they're going to look for. The nurse is caring for the client who has just returned from the recovery room after undergoing abdominal surgery. Select the early sign of hypovolemic shock for which the nurse monitors the client. Increased pulse rate, increased depth of respiration, lethargy, decreased deep tendon reflexes. So 91% said pulse rate, 5% said respiration or deep tendon reflexes. What's the key word in this one? Early sign of hypovolemic shock. Because when we get to that shock and sepsis unit that we're going to talk about in a few weeks, you'll learn that there's phases of shock and that there's certain signs and symptoms you'll see in the earlier stages and those that you're not going to see until the late or end stage. Increased pulse rate is always the first thing you're going to see. That's the first compensatory mechanism that your patient is going to exhibit as they start to lose blood volume, lose oxygenation. Next thing, probably increased depth of respiration that you'll see. The lethargy, the DTRs, those are going to be way down in the third or fourth phase of shock. Strategy 3, using guidelines for prioritizing. We're going to touch briefly on this now, and when we go into professional issues next week, a lot more on prioritizing, because again, it's a huge portion of the NCLEX. You're going to be asked to prioritize. Again, the key words are going to be things like the best, the first. They're going to give you, you've taken report on these 4 patients, who are you most concerned about? Or you've taken report on this patient, what is your primary concern? You've given the patient this particular medication. What is the first thing you're going to assess them for? So you have to think, complications, side effects, that sort of thing. So one of the ways that you can prioritize is using ABCs. And I like to say that airway is almost always the first priority. Because you've had it drummed into you, ABCs are the priority. But if the scenario has nothing to do with airway or breathing, then that airway or breathing option that those sick, twisted people who write these questions put into there as an option, because they know you've had it drummed into your heads from day one that ABCs, you got to check and see if airway or breathing has anything to do with the scenario that you're looking at. If they're talking about a person who's just fractured their ankle, airway and breathing is not your priority. Circulation is going to be your priority, right? So, almost always the first priority. Prioritize based on Maslow's hierarchy. Physiological conditions and interventions and nursing diagnoses are always going to take precedence over psychosocial issues. So even though all these psychosocial and physiological things might be part of the care plan, they want you to prioritize based on Maslow, and then maybe you'll get to 2 physiological ones and you may have to use the ABCs to prioritize further. Or you can use the steps of the nursing process. That can help in terms of your prioritization of what are you going to do first or next. So the client with cancer is receiving morphine 10 milligrams sub-Q every 3 to 4 hours for pain. Select the priority action the nurse includes when preparing the plan of care for the client. Monitor stools, monitor urine output, encourage the client to cough and deep breathe, encourage fluid intake. So 4% said stool, 17% said urine, coughing and deep breathing got 74%, 4% said fluid intake. Now all of these are going to be part of the plan of care for that patient on morphine, correct? Are we going to monitor stools? Why? Constipation. How about urine output? They could get urinary retention from it. How about fluid intake? Is coughing and deep breathing relevant to this scenario? Why? Right, because morphine can depress the respirations. So in this particular case, coughing and deep breathing is your priority because it involves airway and breathing. May not in some other scenario that doesn't have that problem. The 32-year-old mother of 3 is brought to the clinic. Her pulse is 52. There's a weight gain of 30 pounds in 4 months. The client is wearing 2 sweaters. Diagnosed with hypothyroidism. Which of the following nursing diagnoses is of the highest priority? Impaired physical mobility related to decreased endurance, hypothermia related to decreased metabolic rate, disturbed thought processes related to interstitial edema, decreased cardiac output related to bradycardia. So what do you think is going to be the highest priority for this patient? Physical mobility, hypothermia, thought processes, cardiac output. So 24% said hypothermia, 5% disturbed thought processes, and 71% said decreased cardiac output. Why did 74% of you pick number 4?
Because of the weight gain. Well, I mean, she's got weight gain, she's got pulse.
So using the prioritization, why did 74% of you pick? For circulation, ABCs. Because if she's got decreased cardiac output, she's not getting enough oxygenated blood to her tissues. Sure, hypothermia is an issue, possibly. Impaired physical mobility can be a complicating issue later on. Disturbed thought processes can be an issue if this patient becomes severely hypothyroid. But decreased cardiac output, because it is a legitimate diagnosis, and it affects one of your ABCs. Assessment is the first step in the nursing process. So oftentimes, the first thing that you're going to do, given your scenario, is gather more data, get more information, do an assessment before you do something. If there's not an option for assessment, then you're probably going to want to do something using the next step of the process. Except in an emergency situation, sometimes doing something, implementing something might be the first thing that you're going to do versus gather more data. But by and large, with a non-emergency scenario on an NCLEX question, gathering more data, getting more information is going to be probably your best selection. So the mother of the 10-year-old boy with type 1 diabetes calls the clinic nurse to discuss the blood glucose results. The child is regulated with a combination of NPH and regular insulin before breakfast and supper. The past 2 mornings, his blood sugar readings are 220 and 210. What should the nurse advise the mother to do? Continue with the medication regime, check the blood sugar during the night, give the NPH insulin later in the evening, serve a bedtime snack earlier in the evening. Oh, I love when this happens. 17% said continue with the medication regime, 21% said check the blood sugar during the night, 38% said give the NPH later in the evening, and 25% said serve a bedtime snack earlier in the evening. So let's take number 1, first of all. Would we want to advise the mother to do number 1? Why not? Right, we've got to do something. So we're not going to continue on with the way things are going. Number 4, serving the bedtime snack earlier in the evening. Would that be the best thing? Well, let's go back to, first of all, to what we're doing. If we've got high fasting blood sugars and he's getting NPH in regular before breakfast, so let's say 7:30, and NPH in regular again before supper, which say about 4:30. Giving him a bedtime snack earlier in the evening, yeah, that could effectively lower his blood sugar for the morning, because what do we know about NPH insulin? Yeah, it has an onset, it has a peak, and a duration. So unlike Lantus, which gives you a steady level of control for the 24 hours, NPH has an onset of usually about 1.5 to 2 hours, and a peak at about 6, 7, 8 hours afterwards, and then a steady decline in the levels for the next 12 hours or so. So if we gave him a bedtime snack earlier in the evening, that could conceivably lower his morning blood sugar, because it would probably get eaten up, quote unquote, by the insulin when the insulin was approaching and getting to its peak level of action. But is that the best thing to do? Yes?
The way I interpreted that question or that answer was like giving an additional snack.
Giving an additional snack.
Rather than,
But why would you want to give him an additional snack? Yeah. Right, you wouldn't want to give him it because he's already high. Now, can we do number 3? Why can't we do number 3? Because it's a doctor's order. We cannot, as the nurse, tell the mother just arbitrarily change the NPH insulin order to later in the evening. The doctor has ordered it before breakfast, before supper. So that's not something that we can recommend or advise that patient to do. So not too many of you wanted to do number 2, which is the correct answer. So somebody want to tell me the rationale for doing that? Yes, Bill. To get more data for the doctor. Obviously, something is happening. I mean, probably what's going to end up happening is the doctor is going to increase the NPH dose at 4:30 in the afternoon. But before the doctor is going to do that, they're going to want to know what's happening to that what happens to his blood sugar when the NPH is at its peak, right? So if we wait until, let's say 8 hours, and we gave it at 4:30, so around midnight, check his blood sugar. That's when the NPH is going to be at its peak. If he's too low at his peak now, then they're not going to want to raise the NPH insulin again, because then he's going to go even lower when it hits its peak, right? So we have to get more data. We have to find out what's happening when the insulin hits its peak at midnight or thereabouts. And then the doctor's going to probably, if the sugar is still not, too low at the peak, then the doctor's probably going to order the NPH at 4:30 to be increased, because that will lower the fasting blood sugar the next day. But we need to get that information. We don't want to continue. Serving the bedtime snack earlier in the evening isn't going to do us any good. And we can't, because we're nurses, order the time of the insulin dose to be changed. So gather more data, that's what we have to do. Any questions? Analysis. A lot of your questions are going to be, you've given the patient this particular medication, what do you expect is going to happen? So the cause and effect, knowing what the cause and effect is, based on a medication you might be given, based on a diagnosis that the patient might have, based on a laboratory test or a diagnostic test that might have complications or side effects or PrEPs. You need to know that cause and effect. So you need to look at that, and then you also need to be able to figure out what's the rationale for what I'm doing here. Why am I doing what I'm doing? What am I looking for? What's my cause for concern? So I don't know how many of you remember this particular question from back in 110 and how we kind of talked our way through it, because nobody at that time knew what hypertrophic pyloric stenosis was. But you have a baby with that, and you want to select the laboratory finding you would expect to note in the infant. Blood pH of 7.5, pH of 7.3, bicarb of 22, bicarb of 19. What would you expect to see with this particular condition? Now, before we read the results, I was hoping it wouldn't show it. 78% of you picked the pH of 7.5. 17% said 7.3. 4% said the bicarb of 22. I'm just going to go back. Whoops. So we can actually see the question. Okay, so now you've had PD and OB. Did you learn about hypertrophic pyloric stenosis? So you know the baby's got projectile vomiting. But if you didn't know that, does anybody remember how we did it back in Nursing 110 and talked our way through it? We talked about medical terminology, hypertrophic. We talked about anatomy and physiology, pyloric, the pyloric sphincter at the base of the stomach. We talked about stenosis, stiffening, narrowing, hardening. So putting that all together, we determined the baby was going to have projectile vomiting. And then we talked about what it is that we lose when we vomit, in addition to the food that was in our stomach, is acid. So the patient is losing acid, so are they going to be in a state of acidosis or alkalosis? Alkalosis. And then what pH tells you that he is in alkalosis? 7.5. Because what's our normal? 7.35 to 7.45. So anything below 7.35 is going to be acidosis. And then we're also, when we talk about ABGs and we get into respiratory, I'm going to give you like kind of a quick and easy way of looking at analyzing those ABG questions that you get on the NCLEX. And the first thing I always look at is the pH, because that's going to tell me if they are in acidosis, alkalosis, or if they're compensated. Bicarb is kind of irrelevant in this particular situation because the patient is losing acid. They're elevated bicarb anyway. Okay, prioritizing your diagnoses. Next step of the nursing process, planning, getting your goals and your outcome criteria, developing and documenting your plan of care. Actual nursing diagnoses are going to take precedence over potential nursing diagnoses as long as they both fit the scenario. So if you have a potential or a risk for nursing diagnosis, unless it's the only one that fits that patient scenario, you're probably not going to pick that one. You're going to go for something that is actual. So the nurse develops the plan of care for the patient with cataracts. Select the priority nursing diagnosis. Fear related to loss of eyesight, social isolation related to decreased ability to move about in the community, disturbed sensory perception, visual related to ocular lens opacity, risk for injury related to decreased vision. And all of you picked disturbed sensory perception. How come nobody picked risk of injury? Safety, safety first. It's not an actual. Does disturbed sensory perception fit the? Yes. Hey, 100%. I kind of don't like when that happens. No, I do. No, that makes me, okay, they've learned something great. Okay, implementation. The process of organizing and managing care, counseling, and teaching. This is a test of nursing process, nursing practice. So they want to make sure that you're focusing on the nursing actions versus medical actions. They also aren't going to want you to turf off the action to another profession unless it's the only possible option that you can do. You're only going to focus on that client that's in the question. Again, taking those what ifs and the other things that might be happening. It's your only client, just like in nursing school. It's the only patient that you have to worry about. And it's going to be the textbook perfect view, which means not the way you saw Nurse Nancy do it the other day, not the way a particular disease process worked in your family or your personal experience, what side effects you may have gotten from a particular medication, because you may have been that 1 in a million that got an anaphylactic reaction to a medication that it's like one of the least likely things that's going to happen with that particular drug. So you can't go by personal experience, what you've observed. You have to go by what the textbook says, what to expect, what side effects, what things are going to happen based on what you know about the perfect situation. Of course, that's never real life. So the nurse is caring for the client with angina, begins to experience chest pain. The nurse administers a sublingual nitro as prescribed, but the pain is unrelieved. Select the action you would take next. Contact the physician, call the family, administer another nitro, reposition the client. Now, 92% are going to give another nitro, and 4% are going to either reposition or call the doctor. So what do you know about this particular question that tells you that 92% of you were correct on this answer? You can give more than one. So taking the knowledge that you know that when a patient is prescribed nitro, they're going to get 3 doses max every 5 minutes if no relief, from the previous one. And then you're either going to put into place whatever protocol the doctor has written, or you may have to call the doctor if you don't have any other orders after that 3rd nitro. Or what I would tell my patients in home care is call 911. Do not try to drive yourself to the hospital if after 3 nitro have not relieved your chest pain, or even have your family member drive you to the hospital. So administer another nitro. And the reason we know that we can do that and we're not reading into the question is that the patient begins to experience chest pain and has received a sublingual nitro. So you know based on your textbook version of how nitro is prescribed that that patient can receive at least, can receive 2 more doses of nitro before you have to do anything else. Comparing your actual to expected outcomes. That part on your nursing care plan, was the goal met, not met, why? And making a judgment based on how that patient has responded to a medication, a diagnostic test, the disease process that they're asking you about. You're also going to be evaluating the patient's ability for self-care, because in NCLEX, they really want to push for patient independence, patient autonomy, doing things that or implementing things that are going to involve the patient in the plan of care before you just arbitrarily do something with that patient. You also need to be aware, and we'll talk about it when we get into delegation, is the team member's ability to perform the care. What tasks you can actually give to a particular class of employee before, that's appropriate in terms of scope of practice and legalities and that sort of thing. So many of your NCLEX questions are going to involve something like this. The nurse evaluates assignments on the medical surgical unit. The nurse determines assignments are appropriate if a nursing assistant performs which of the following tasks: encourages the client to practice post-op exercises taught by the RN, irrigates the NG tube of the patient receiving a tube feeding, covers a skin tear with a transparent dressing, determines the effectiveness of the restraints for a client in Buck's traction. So 91% said encouraging the client to practice post-op exercises, 4% said covering the skin tear or effectiveness of the restraints. Now, this is where you have to be very careful and remember when you're doing these delegation questions is taking out of your head anything that you may have seen delegated to you or the CNA or the tech or the LPN, and look at the textbook requirements that we're talking about. Now, in home care, many, many times, the home health aides would remove and replace a Tegaderm, which is a transparent parent dressing, over like as a skin protection. May have seen PCTs do that with a patient who has a skin tear in the hospital, and they tell the nurse about it, and the nurse says, okay, put a Tegaderm on it, and clean it off and put a Tegaderm on it, and I'll come down and check it later, but we want to protect it. Even though you've seen that delegated, you need to go on these delegation questions, pick the least complex, lowest level of training and education to delegate to that lowest level of practitioner. And it's not an insult to the person who works as that. It's you have to look at these delegation questions in that way, or you're going to go around in circles about things that you've seen delegated, and it could have been legal to delegate it, but it's not the best answer to the question when they're talking about the least level of training and education. Encouraging them to practice the post-op exercises that have already been taught is something that is probably the least technical thing on that list of options. Obviously, you're not going to delegate the irrigating of the NG tube, and the effectiveness of the restraints. Determining effectiveness, that's an evaluation. And that is part of the nursing process, and that is something that you cannot delegate to anybody. So evaluating that those restraints are effective, any kind of evaluation of effectiveness is something you cannot delegate. True or false option questions. Now, most of your multiple choice questions are, pretty much a true option question. They give you a scenario, you pick the correct answer. False option questions are the ones where they give you the scenario, but the way the question is worded, you have to pick the wrong answer because that's the right answer to the question. And usually it ends with which statement by the patient indicates the need for further instruction. So you always have to pick the wrong statement by the patient because that's the right answer to the question. And or they may say which action that you observe the patient doing or the new grad doing requires your intervention. So it's the wrong thing. The best way to deal with these types of questions for the false option, as I'm going to show you that technique in just a minute. This is a true option question. Patient with suspected meningitis scheduled for diagnostic tests. Select the diagnostic test the nurse anticipates will be ordered to confirm the diagnosis. Electrolytes, electromyography, WBCs, lumbar puncture. And all of you probably remember from Nursing 110, lumbar puncture. But why did you pick lumbar puncture? Because what did the question want you to do? The question is asking you to differentiate between all kinds of different tests, lab tests and electromyography where they test peripheral nerve function, to see what is the definitive diagnosis for lumbar puncture. You may see questions that are a lot more complex than this. In fact, you definitely will see questions that are a lot more complex than this. And what they're trying to get you to do is zero in on what's different about one particular condition versus the others. So in a question like this, you have to look at, okay, would I see serum electrolytes being drawn on just about everybody, not just the patient with meningitis? Yeah. Same with the electromyography. You're going to see that with peripheral nerve disorders, but not with a meningitis. WBCs, yeah, that's going to be part of their diagnostic profile, but that's not going to confirm that they have meningitis. Only the lumbar puncture is going to do that. Cortisone, prescribed for the client with adrenal insufficiency. The nurse provides instructions. Which statement indicates the need for further instruction? I will eat a good breakfast every day. I will avoid people with colds. I'll limit my sodium intake. I'll stop the medication when I feel better. Okay, 5% said avoid people with colds, 95% said I'll stop the medication when I feel better. Now I can tell you when I talk about meds that any statement by the patient that says I'm going to stop or reduce the dose or do anything like that when it comes to my medications is always going to be the wrong answer. and indicate the need for further instruction. But this is one of those false options. And it's a quick read and it's a pretty easy read. But a lot of times you will run into very complicated false option questions where all the answers are very wordy. And by the time you get to option 2, you've completely forgotten what option 1 really said, and they'll stick in little words that kind of blend in that are going to make the option incorrect or correct. So what we're going to do is we're going to treat every single one of these responses as a true-false statement as it relates to the question. And so if you do that, best case scenario is you're going to come out with 3 true and 1 false. And the false one is going to be the correct answer to the question. So is it true that they should eat a good breakfast every day? Yeah, that's always true anyway. Is it true that they should avoid people with colds? Why? Because cortisone is going to lower their immune response. So they should be avoiding people with colds. How about limiting the sodium intake? Why? Well, it's good for you, but how does that relate to steroids? What do steroids tend to make you do? Retain fluid. And what does sodium tend to make you do? Retain fluid. So to add sodium onto steroid therapy is going to make that patient really balloon. But should they ever stop the medication when they feel better? Okay. So we have 3 true and 1 false. So option 4 is going to be our correct answer. And again, fairly simple question, but when you get into those long involved false option questions, that can be a very good technique to use. Okay. There we go. Oh, it's going to be fussy now. Focus on feelings, concerns, anxieties, and fears. Now, therapeutic communication. You just got through with 4 weeks of psych, and probably talked a lot about therapeutic communication. What you want to do, oh, thank you, is they'll be asking you questions on, the patient says this to you, what is the nurse's most appropriate response? So we want to focus on what is the best kind of question that we can ask them. I don't know why that's doing that now. Mother says to the nurse, I'm afraid my child's going to have another seizure. Select the most therapeutic response for the nurse to give the woman. Can you tell me why you're concerned? Most children will never experience a second seizure. Tell me what frightens you most about the seizures. Tylenol can prevent another seizure. Now, 88% of you picked, tell me what frightens you most about the seizures. 12% said, can you tell me why you're concerned? Most children will never experience a second seizure. That's false. It's just a totally false thing. Tylenol can prevent another seizure. No. But why is number 1 incorrect? It's a closed-ended question. But also, the problem with number 1 is it includes the word why. In NCLEX land, they don't like you to ask the patient why because they consider that it's confrontational and it puts the patient on the defensive. Even though in real life you can certainly ask a patient why kind of question and get, and not be confrontational and, be able to gather that information. But if that option in a therapeutic communication question contains the word why, don't pick it. Because there's got to be one better. And oftentimes, the correct answer is worded in a very uncomfortable, kind of not the kind of syntax and the way you would word something. Yeah, where you would look at it and go, I'd never ask a question like that. Or I'd never phrase it that way. But be careful because that's probably the answer because they're going to make the why one, the incorrect one, sound very common and one that you'd always ask a patient and it sounds very comfortable and the syntax is just the way you would say it. Don't be fooled because if it has the word why in it, it's probably not going to be the correct answer. Strategy 6, eliminate similar options. I can tell you that students from from one of the semesters a while ago when I first started doing this before the psych exam said that this particular strategy worked really well on the psych exam that you guys are going to take next week. Just saying. Oftentimes, you're reading it, 3 of the options look really good, 1 of them is different, and the 3 that are similar, you kind of are having a hard time prioritizing which one's the best. Go back and read the question and see if maybe the one that's different is truly the correct answer. Because if they sound alike and there's no real way of prioritizing what's best, then all 3 of them could be wrong and that one that's different is the one that's correct. So the nurse is assigned to care for a group of clients. Which client does the nurse determine is at risk for fluid volume excess? Ileostomy, diuretics, GI suctioning, renal failure. Wow, good. 100% of you picked the client in renal failure. Because why? Right, and what about the other 3? What are they at risk for? Deficits. Now, this, you know all about renal failure, so, you could have answered this question even without looking at those other responses. But what if that diagnosis in number 4 was something you'd never heard of? Pick it anyway, because chances are, you've eliminated the similar, go with the one that's different. So that's going to be particularly helpful if one of those diagnoses is something, whoa, I've never heard of this one, and there's nothing in the name of it that can kind of give you a clue. Eliminate your absolutes. Questions that have only, all, never, always tend to make the response incorrect because, as in real life, nothing is an absolute. The nurse provides safety instructions to the mother of a child with hemophilia. Select the directive the nurse gives the mother in the interest of promoting a safe environment. Remove toys with sharp edges from the child's toy box. Allow the child to play with toys only if a parent is present. Have the child wear a helmet and elbow pads every day. Allow the child to only play indoors. And once again, 100% picked number 1 because? Because it didn't have any absolutes in it. Number 2 has only, number 3 has every day, number 4 has only play indoors. The umbrella option, and this is one that you probably won't see a whole lot, but occasionally you will see a question where all 4 of the options are correct. All of them look equally good and don't really give you any clues as the best way to prioritize based on, the ABCs or, Maslow and all that. So how do you decide? Oftentimes, one of the options is kind of a global umbrella option that kind of encompasses everything that's included in the other 3. And oftentimes, that's the best thing to do. So the nurse in the ED takes a telephone call from the EMS that several survivors of a plane crash suffering from cold exposure are coming to the hospital. Select the nurse's initial action. Supply trauma rooms with bottles of sterile water and normal saline. Call the laundry to ask the department to send warm blankets. Call the nursing supervisor to activate the disaster plan. Call the ICU to get nurses sent to the ED. Okay, 11% said get the warm blankets, and 89% said activate the disaster plan. Why did 89% pick number 3? Because it's the global option, and if you do that, then everything else is going to take place. Because you can't really prioritize whether you should get the saline there first, or whether you should get the warm blankets there first, or whether you should get people to come down, transfer down from the ICU. But if you call the supervisor and get that disaster plan in operation, then everything is going to fall into place, and the people that need to do the jobs that they have to do to get all those things to the ED are going to take care of it. Next thing we're going to talk about is delegation. Delegation guidelines. Again, a vast majority of your NCLEX questions are going to have delegation as a part of it. And we're going to spend a lot more time when we talk in the professional issues section after the psych exam next week about how we delegate, what criteria we use for delegation. But what you need to know is you need to remember in NCLEX land that nursing assistants, techs, CNAs, you're going to delegate non-invasive tasks. And when you're looking at the question and they ask you which is the most appropriate to delegate to that lowest level of practitioner that you're going to be delegating to, you always pick the least complex patient, the least complex task, the one that requires the lowest level of intervention and action and education and training. You have to have that in your mind and get all those other scenarios out of your head that have had certain things delegated that weren't wrong to delegate, but they're not necessarily the correct answer for that question. LPNs, and this is a really tough one for LPNs, and I wish Michael was still here, because LPNs that really struggle with the kinds of things that they're supposed to be able to legally delegate as RNs, contrasting that to things that have been delegated to them as LPNs throughout their practice. And I started off as an LPN, and I am astounded at the things that I had delegated to me in the 9 years that I was an LPN, that when I look back, I go, not according to my scope of practice, not according to the RN scope of practice. Because when you delegate as an RN, you cannot delegate the nursing process. You cannot delegate the initial assessment of the patient. How many of you have been in long-term care facilities and LPNs are running the floors and the units, and you've got one RN in the building, if you're lucky? Somehow, somewhere along that chain of command, some RN is co-signing those initial assessments that those LPNs are making when they come onto that unit, or they would never pass their state survey. But technically, by the book, textbook, as an LPN, they should not have the initial assessment when that person comes to your facility delegated to that LPN. So the initial assessment has to be done by you or another RN. If they're coming from the ED to your floor, from the ICU, from the PACU, transferred from the hospital to your long-term care facility, anytime an initial assessment has to be done, it's got to be done by the RN. Initial teaching has to be done by the RN. LPNs can continue on with teaching, they can continue on with assessments, but you cannot delegate those initial processes. That is the nursing process. LPNs can give medications, do many invasive tasks, but because the NCLEX is a national exam, and in some states LPNs are not allowed to do anything with IVs, you cannot delegate IVs to an LPN on an NCLEX question. Because some states, because it's a national exam, it has to be normed for the national norm and national average, and they can't. It would be unfair to a state that doesn't allow LPNs to do IVs to get a question like that and be marked wrong on it, because when in their state, IVs cannot be delegated to LPNs. So for NCLEX purposes, you're not going to delegate IVs to the LPN. You're not going to delegate initial assessments, initial teaching to the LPN. Ongoing reinforcement, those kinds of things can be delegated. Another thing that in many states, depending on the area of practice, LPNs cannot take doctor's orders. So as a national exam, you're not going to delegate the calling of the physician to obtain orders to the LPN. Now, some states, LPNs can take orders in long-term care, but can't take them in acute care. I mean, every state has different regulations. So given, again, that it's a national exam, you want to make sure that you're not delegating IVs, taking of doctor's orders to that LPN. So anything that involves the nursing process, initial assessment, initial teaching, IV medications, evaluation of the care plan, evaluation of anything, if that word is in that question, it's got to be done by the RN. So the Nurses Planning Client Assignments has an LPN and a CNA on the team. Select the client the nurse most appropriately assigns to the LPN. The client with stable congestive heart failure has early stage Alzheimer's. Client with dehydration, weak, needs assistance with bathing. The client with emphysema, receiving oxygen at 2 liters by nasal cannula and becomes dyspneic on exertion. The client scheduled for an EKG and a chest x-ray. Okay, 27% said stable CHF, early stage Alzheimer's, 14% said dehydration, assistance with bathing, 50% said emphysema, and 9% said patient waiting for the EKG and the chest x-ray. So they're asking you, and this is a very common question, you've got 2 levels of practitioner, LPN and CNA, which patient are you going to give to the LPN? In this scenario, you have to pick the most unstable patient to give to the LPN, because that is the higher level of practice. If they had asked you if they ask you in a question, you've got an LPN and a CNA, which one is safe to give to the CNA, then you're going to do the opposite. You're going to pick the patient that is the most stable, the least risk for complications and problems to give to the CNA. So in this case, stable congestive heart failure, early stage Alzheimer's, perfectly safe to give to the CNA. It even says stable in the answer. Dehydration, weak, needs assistance with bathing, perfect patient to delegate to the CNA. Scheduled for an EKG and a chest x-ray, we don't know anything else about that patient. So we can't say, well, what if he needs teaching? What if he's having chest pain? What if this? What if that? We don't know. He's just hanging around waiting for the EKG and the chest x-ray. So you could have the CNA check in on that patient. There's nothing to say there that you can't. The patient with emphysema, who's on oxygen, who gets short of breath on exertion, the LPN is going to have to do it, because there is a certain level of assessment that needs to be done. There's a potential for risk and problems. So always look at that from that point of view. Okay, medications. The client should never adjust or change or stop the medication. So don't pick that. You're never going to recommend the patient take an over-the-counter drug. That's not a nursing action. Has to be cleared by the physician. We're not going to give the med when the order is difficult to read, unclear, or an abnormal dose. You're going to be expected to know certain common medications. They're not going to ask you something really out in left field, but common medications, or comparing, when you change from, say, an IV to a PO version of a med, what's a common dosage for a particular medication? You should, if the medication, and you should always know this, that if it doesn't meet the rights of medication administration, if that order is not complete, then you've got to question it. If you can't read the order, you've got to question it. So if you work in one of those facilities that still has handwritten doctor's orders and you can't read it, you don't get a group of people around trying to decide by committee what it says. And you've probably seen that in some facilities. They're, hey, does anybody come over here? And they all kind of gather around the chart and try to figure out what the doctor meant. No, somebody's got to get on the phone and call the physician. The question on an NCLEX question is always going to give the trade and the generic name of the med. So if one of them looks familiar, then it's going to give you a fighting chance. If there's a medical diagnosis in the question, link that with the drug. There was a time, probably a couple of years ago, and I think it just happened with one cohort, students were coming back and telling me that they were asking questions like, you are giving the patient this med. And that's all it said on the question. Didn't give a diagnosis, didn't give any other information. What would you expect to see as a common side effect, or, words to that effect? And, they were meds that they had never seen before. Now, that's not really a test of nursing practice, because if you've never seen the med before and you've got no surrounding data, you're always going to look it up. So they were basically testing people on something that you wouldn't do in practice. And they never showed up. I've never had students tell me about that since then. So I think those were those certain percentage of field test questions that they put on the NCLEX that they throw out, that they're just testing for statistical validity and reliability, and they determined that it was probably not a good idea. Commonalities in med names to identify the classifications. You know that the OLOLs are the beta blockers, the PRILs are the ACE inhibitors, the Mysins are antibiotics. So what you've learned about that particular class of medications, you can put into that question, because maybe the PRIL that they're using predominantly on the East Coast may not necessarily be the brand name of PRIL that they're using in California. And people write these questions are from all over the country. So a common beta blocker that they're using a lot in California may not necessarily be one that rings the bell with you, but the generic will probably have the OLOL at the end, and you know about beta blockers. If you don't, you will by the time you get through with this course. And then you'll be able to answer that question. Classification, you know that certain side effects are related to certain drugs, then apply that to the question. If you know that it's certain common side effects, then that can help you to prioritize what you're going to be assessing or doing first. And when all else fails, look at the name of the med and see if there's something in that brand name, oftentimes, that can give you an idea. If the med has the word press in it, then you could say, well, gee, maybe it's a blood pressure med, and give you a fighting chance to answer the question. Because you don't want to skip over questions. The NCLEX, they give you a minimum of 75 and a maximum of 265 questions, and you have to prove to the computer within that range of 75 to 265 that you are competent. So the more questions you answer correctly, the sooner you can prove your competence, or worst case scenario, incompetence, because it will shut off at 75 questions if you fail. So don't think that if it shuts off at 75 that you're guaranteed that you passed, because I have had students come back and they have failed. Conversely, I've had people go all the way to 265 and were convinced that they had failed, and they passed. So don't get nervous about that either. So we have Synthroid, 50 micrograms daily. Patient has hypothyroid. What's the time at which the nurse tells the client to take the medication? Just after breakfast, with a snack at 3, in the morning on an empty stomach, with food. Now, 13% said after breakfast, 79% said in the morning on an empty stomach, 8% said with food. Now, if you didn't know, 79% of you answered it correctly, in the morning on an empty stomach. Some of you may have answered it that way because you knew that that's when that particular drug was supposed to be given. But what technique could you have used if you didn't know that? Yes, Mark? Right. Eliminate the similar, pick the one that's different. 3 of the options involve food, 1 doesn't. So if you've never seen Synthroid, they've given a drug up there that you've never seen, you haven't given it, you don't know that it needs to be given before breakfast, and there's a lot of medications out there, and until you look them up, many times you don't know if they're empty stomach, full stomach, with food, avoiding, 2 hours before or after you've given an antacid. I mean, there's all kinds of restrictions. But on this one, all you had to do was eliminate the similar and pick the one that's different. Select all that apply. You all love that. And the problem with select all that apply is you don't get partial credit. It's an all or nothing. You either select all that apply, and if you miss one or you add one, the question is wrong. And so usually it's, you read the scenario and you're confronted with a list of options, and by the time you read all the options and get to the bottom of the list, you can't remember what the top of the list said, and you're getting them all jumbled up. So we're going to use the same technique that we used with the false option questions. We're going to use that for select all that apply, and it truly does work. The client is having difficulty with the motor aspects of speech, difficulty forming words, has a nasal tone. Select all of the communication strategies the nurse would use when working with the client. So this is where we read the question and then we say, each option, is it true or false as it relates to the question? And that's really important because it could be a true statement taken out of context, or it could apply to another scenario as true, but it could be false in this scenario. So you always have to look at it as it relates to that question. So in this case, would we repeat what the client said to verify the message? True. Would we encourage the client to speak quickly? Why? Right, he's having trouble forming words. He's having problems with the motor aspects of speech. Would we nod continuously while the client is speaking? Why not? Plus, it would drive him nuts. I mean, if somebody's like nodding at you all the time. Plus, it has an absolute in it. So you would want to eliminate that one because of that absolute. Not only would it just drive the patient crazy. Engage the client in lengthy discussions to strengthen the voice. No, not in this case. Now, maybe another patient with another type of speech pathology might have that type of therapy where they have to where they're having long conversations. Ask questions requiring a yes or no. True. Use a letter board or a picture board. True. So here's our select all that apply. All of your true statements are true. True. So A, E, and F is our select all that apply. This is a very good strategy to use, especially when you've got a list of signs and symptoms. Many times they'll say, these are all these are signs and symptoms, select all that apply to a particular disease process. Use that. It's a really good process. How many of you have changed answers on an exam? How many of you have changed the answer to the wrong answer? And did you find that most of the time you changed the answer, it was to the wrong answer? You were right the first time. And the reason that you were probably right the first time is because the first time you saw that question and you got it down to those two really good responses, and you spent a couple of minutes agonizing and using your prioritization and your strategies and everything that, all your critical thinking to apply to that question, and you finally decided that A was the right answer because you really thought it through and you strategized. But, you may have had a little niggling doubt in the back of your mind, but primarily you figured A was the correct answer. And then you continue on with the exam and you got a little bit more time and you want to go back and review your answers. So you go back and you review your answers and you flag that one because you had a problem with it. And in the 5 seconds it takes you to read that question again, you change it to B. Not because you had any concrete, confident, light dawning on Marblehead kind of thing that, that you picked the wrong answer to begin with. And the majority of the time you're going to change it to the wrong answer because you changed it with doubt. You didn't change it with confidence. You didn't change it because you went back to it and said, oh, geez, A is obviously not the correct answer. I meant to bubble in B, and I just bubbled in the wrong answer. Or picked the wrong one on the computer.
Or if you find or later on, if you come across a question that really jogs your memory, oh, there you go.
That can happen. Sometimes you'll have a question later on that jogs your memory, but be real careful.
Yeah.
Because what was the correct answer to question 35, that's very similar to question 4, there you go back and you read very, very carefully. Again, with confidence, not with doubt, because there could be something in question 4 that makes that answer wrong for question 4 when it was the correct one for question 35. Yes? You cannot. That is the one thing about the NCLEX questions. You can change your mind 1,000,000 times before you submit the answer, but once you submit the answer, it's gone. It's gone into the ozone because it's a computer adaptive test, and they base your next question on how you answered the previous question. So they start everybody off with a medium difficulty question, and then depending on how you answer it, they will move you on to something a higher difficulty, or if you answered it wrong, they may ask you something along the same lines as that first question. So if you find that your questions are starting to become a trend in one direction, like, you know, people coming back and saying, wow, there was a lot of psych on that exam, that's because they weren't answering the psych questions correctly. So if you find that you're getting a lot of a certain type of question in a row, kind of stop and take a look and say, I better rethink my strategy here, because I'm thinking maybe I didn't answer those other questions correctly, because they keep shooting that same topic at you, or the same, or like a select all that apply. Somebody come back, they said every single one of their questions was select all that apply. I said, probably because you kept answering them wrong. You know, it wasn't quite every single question, but you know, the hyperbole of coming out of these kinds of situations. But yeah, if you start to see a trend in the types of questions you're getting, the content, or the, you know, stop and think. I'm obviously haven't proven to the computer that I know my stuff about this particular concept. Yes?
That's interesting to know. So does that mean if, let's say they hit you with 3 psych questions and you blow them all, will they throw another one in there, you know, not a psych question, something else, then go back to the psych
They
question?
might.
Okay.
They might.
Watch for it.
Yeah. Yeah. But, and again, it's, you know, 75 questions, it takes the minimum of 75 questions to prove that you know your stuff. But it could shut off at 120, it could shut off at 200, 235. You still, yeah. And again, I have had students that have gone all the way to 265 and were convinced that, that they failed and they passed. And I've had students, you know, have it shut off at 80 and thought they passed and they didn't. So again, changing your answers. So on the NCLEX, unlike the NLN exams and the Blackboard exams that you'll be taking this semester, where you can go back and look at that question, be very, very careful that you don't change that answer unless you're absolutely positively sure that you were wrong the first time. On the NCLEX, once you finally make your decision and agonize over it for however many minutes that you wasted on that, you know, you can't go back. Yes?
When I was taking the GREs to get into our master's program, another strategy they taught us was, let's say you do all the strategies you taught and you're still clueless on the question, right? If you skip the ones you truly don't know, and then you already go into the test saying that if that ever happens to me, every one I have to go back in and answer, I'm either going to do A, B, C, D, or E, and just be consistent.
Yeah.
50% of those right.
And unfortunately on the NCLEX, again, you can't go through, you can't do that. You've got to answer the question, and the more questions you answer, the better the chance is that you're going to prove to the computer that you know your stuff. You know, try not to skip answers, you know, or just, you know, sometimes it is a coin flip. You know, you get it down to those 2 and you just can't, and you're looking at it and you're saying, I can't waste any more time on this question, I'm just going to pick one. At least if you've gotten it down to 2, you've got a 50-50 chance. The next strategy is going to be on covering your answers, and some people this will relate to, and other people will think I have 2 heads when I talk about it. But some people will start to read the question, they think they know where the question is going, and they think they might be running out of time, so, oh, I know where this question is going, and they just look at the answer. They don't finish reading the question, and they look at the answers, and one of the answers jumps out as being really good. You know, it's worded the way they would think it should be worded. It's got all the buzzwords. It's got things in it that, you know, that we as instructors have drilled into you, you know, for the last 5 semesters. So you go with that, and then you say, oh, wait a minute, Pam said I got to read every word of the question. So you go back to read the question, and because you picked that answer as the correct answer, when you go back and read the question, you change the meaning of the question to fit the answer that you've already picked. That's going to make you skip things like except, or, yeah, these are, you know, all of these fit this particular scenario except, and you go and you pick something that actually fits the scenario. So if that's something that you know that you do, and you know who you are if you do that, cover the answers with a piece of paper. If you're in an NCLEX situation and they give you a whiteboard instead of a scrap paper, put the whiteboard up in front of the computer and cover up the answers. And you can do that on your exams here. Take your scrap paper and just put it up over the answers. Read the whole question, every single word, and then, and even at that point, before you even look at the answers, formulate in your brain what you think might be the correct answer. And oftentimes when you uncover the answers, an answer will jump out at you that's exactly what you were thinking, or very, very similar to what you were thinking. But at least you haven't changed the meaning of the question to fit the answer that looked good when you read it too soon. So that is it for the strategies, and so we're going to spend the rest of our time doing some practice questions with the clickers. So, the woman during the transition phase of labor complains of lightheadedness and a tingling sensation in her fingers. Which of the following actions should the nurse take? Get your clickers out. Oh, I'm sorry, I should read those. Have her breathe into a paper bag held tightly against her mouth and nose. Encourage her to pant and blow with the next contraction. Instruct her to take a cleansing breath and refocus her concentration. Tell her to pant 3 times and exhale against pursed lips. Okay, 27% said breathe into the paper bag, 5% said pant and blow with the next contraction, 41% said take a cleansing breath and refocus, and 27% said pant 3 times and exhale against pursed lips. So, reading that question, what is it describing? What's happening? She's hyperventilating. Because normally you should not have lightheadedness and a tingling sensation in your fingers when you're in labor. But if you're hyperventilating, then you need to do something to take care of that. And what is hyperventilation? What's the definition of hyperventilation? Yeah, you're blowing off too much CO2. So what you need to do is to rebreathe some CO2, right? So number 1 is the correct answer. Numbers 2, 3, and 4, and this could be an eliminate the similar and pick the one that's different. All 3 of those are methods of breathing and concentration and focus that you teach women that are going through labor. You know, Lamaze was real big when I was having my kids back in the 70s and early 80s. You know, I don't know if they push Lamaze as much anymore, but there are certain techniques that you can use for breathing and focusing and allegedly eliminating or decreasing the pain. It didn't seem to work.
So if you concentrated on the transition word, transition phase, you're going to pick romance?
Correct. Because you're looking at something that's not something that you would expect. You would, yeah, that tingling and lightheadedness, that's something out of the ordinary. So you want to say, okay, what do I know? You know, and even then, even if you didn't pick up on that, the fact that all 3 of these, how would you prioritize which one to pick? Because they're all breathing techniques that you would be teaching the patient, you know, that they would have learned through the phases of labor. The woman is admitted to the hospital with a ruptured ectopic pregnancy. A laparotomy is scheduled. Preoperatively, which goal is most important for the nurse to include in the plan of care? Fluid replacement, pain relief, emotional support, respiratory therapy. Forget, this is acting up. Okay, very interesting. Okay, we have 28% said fluid replacement, 36% said pain relief, 20% said emotional support, and 16% said respiratory therapy. So let me go back here so we can actually see this. Let's look at number 3, emotional support. Why would that not be the most important? It's psychosocial, it's not physiological, so that's not going to be your priority. It's going to be part of the plan of care, but it's not going to be your priority. Respiratory therapy, is that something that preoperatively we're going to be worried about? No, that's post-op. if, she has some, if she, turning and coughing and deep breathing, and, and if, say she has some underlying respiratory issues, that could be, nebulizer treatments and stuff like that. But the question's not even telling you that. So again, that's one of those where you don't want to prioritize based on ABCs, because respiratory, really doesn't fit the scenario. So we've got a lot of people with fluid replacement and some more people pain relief. So advocate to me for your answers. Who liked fluid replacement? Yes.
Well, I thought it was ruptured, so she's losing fluid and we would go into surgery.
Right, so she's ruptured, so she's losing fluid, and so she might have some issues preoperatively. How about the pain relief? Yes.
Again, it's ruptured, and that's really painful, and so you're going to want to...
Treat the pain. Okay. Mm-hmm. Yeah, pain is huge. Pain is huge. Fluid replacement is huger. Because now, your name again? Donna. As Donna said, this patient has a ruptured ectopic pregnancy. So we know right now that she's bleeding internally. If it was just a plain old average run-of-the-mill ectopic pregnancy, pain control would be an issue because it is a very painful, but usually the pain comes with the fact that it's ruptured and they bleed out very quickly. So if we cared about pain relief more than fluid replacement, she would die from hypovolemic shock, but she wouldn't have any pain while she was dying. She would die pain-free. So we could mark that off as a goal that was achieved. Pain control, that the patient expressed pain less than 3 on a scale of 0 to 10. But unfortunately, she died. Because, so again, so this is one where airway and breathing isn't an issue, but circulation, prioritization based on circulation is our most important thing. We want to make sure that she doesn't go into hypovolemic shock. Pain is an issue, and we're going to be treating both probably simultaneously, but in NCLEX land, they want you to strategize and prioritize based on the severity and the issues that is the most critical. And like I said, we could medicate her for pain, but if we don't address the fluid issues, she's going to die a pain-free death. Which is nice for a hospice goal, not so nice for a woman that's had a ruptured ectopic pregnancy. The nurse cares for a 15-year-old boy undergoing peritoneal dialysis. The nurse infused 2,000 mLs. Later, 1,000 ml is returned. Which of the following actions by the nurse is the most appropriate? Turn the patient from side to side, push the catheter in farther, milk the catheter, press on the patient's abdomen. Okay, 70% said turn from side to side, 4% push the catheter in farther, 9% milk the catheter, 17% press on the patient's abdomen. So what we want to look here in NCLEX land, one of the things that they always want you to do, if it is effective, do the least invasive approach first. If it can meet your goal. And solve your problem. So why is turning the patient from side to side the best thing to do first? It's the least invasive, and the fact is that probably if you just flip them over to the other side, the dialysate will slosh over to the side where the catheter is, and the rest of the solution will drain out. Push the catheter in farther, absolutely not. That can cause peritonitis. You're instituting bacteria into the patient's abdomen. Milking the catheter, we know that it's patent, so it's a rare thing that it's going to clog off after 1,000 mLs have come out. So milking it isn't probably going to be the best thing. Pressing on the patient's abdomen isn't really going to help. You've got to, shift his position. So the least invasive first is oftentimes the best choice. The 18-year-old had surgery yesterday for repair of a right torn rotator cuff. Although Demerol 75 is ordered Q3 PRN, he's refused the medicine surgery. During the morning rounds, you notice the patient's teeth are clenched and he's diaphoretic. Which action by the nurse is most appropriate? Administer the Demerol 75 as ordered. Explain that taking the medication will not lead to drug addiction. Ask the patient if he's experiencing any pain. Ask the patient why he has refused the medication. Okay, let's get the... Okay, 14% said administer as ordered, 14% said explain taking it won't lead to drug addiction, 52% ask if he's experiencing pain, 19% ask him why he's been refusing the med. So are we going to do number one? Why not?
He has the right to refuse.
He has the right to refuse. So if you give him that medication, you're committing assault and battery. Literally, legally, you are. Explain that taking medication will not lead to drug addiction. Why is that incorrect? Right, you don't even know if that's why he's refusing it. So you're making an assumption that, it is almost a stereotypical kind of assumption. He's 18 years old, so therefore. Most of you said ask him if he's experiencing any pain. Why is number 4 not correct? Because it has the word why in it. So even though in real life you would probably be saying to that, hey Ed, you'd probably be saying to that patient, why are you refusing your medication? In NCLEX land, that's confrontational, puts the patient on the defensive. So you first have to ask him if he's experiencing any pain. Well, obviously he's experiencing pain, right? You don't know. You don't know for sure. His teeth are clenched and he's diaphoretic. Yeah, that's kind of common nonverbal, signs of pain, but he could have also just gotten off the phone after having a fight with his girlfriend and he's really pissed off and he's upset. Could have nothing to do with pain. You got to find out, are you experiencing pain? Where is your pain? What's the level? All those good things that Ed taught you in Nursing 100 about evaluating. They do, Ed.
My favorite question.
Mm-hmm.
So, who wants to answer for me? What's the normal with the normal limits heart rate? Okay, I'm happy with that.
Yes.
Okay. How about systolic? What's the normal limits for systolic? What is it? Well, then they're doing pretty well because
Yes.
we just gave a very similar quiz to some senior nursing students and 40% of them got it.
Not here. Not here.
How about pain assessment?
Oh, okay.
Remember those 10 questions?
Okay, the nurse plans care for the 23-year-old female with toxic shock syndrome. Which of the following actions should the nurse take first? Sit with the patient to reassure her. Administer normal saline at 150 an hour into the right forearm. Administer Cipro over 60 minutes. Teach the patient to use pads instead of tampons during her menstrual period. And I'm telling you that all of those are orders. That, those are all, you have orders for everything there. So. I kind of deleted parts of the question so it would fit on the slide. Okay, 12% said sit with her to reassure her. I love this. 41% said give this normal saline. 41% said give Cipro. 6% said teach her to use tampons instead, pads instead of tampons. Well, first of all, why is number one not a priority? It's a psychosocial issue. It's not a priority in this scenario. It's part of the plan of care, but not your priority. Same thing with number 4. You're going to be doing some teaching, but that's not your priority right now. So half of you essentially wanted to give the normal saline, half wanted to give the Cipro. So advocate for me. Yes?
Normal ceilings for a fluid volume deficit, which takes priority over antibiotics.
Absolutely. She got it in a nutshell. The sodium chloride is taking care of a fluid volume deficit. She's in toxic shock syndrome. Think of shock, think of fluid deficit, except cardiogenic, which we're going to talk about in a little while, where the patient's in fluid overload, but every other kind of shock, they're going to be in fluid deficit. So she's losing fluid. She needs fluid replacement first before the antibiotic. Now, you know in real life, probably you're going to have the IV and the antibiotic all ready to pump it into her at the same time. But again, the NCLEX is asking you to prioritize based on your methods of prioritization. What is the most acute problem? You've got to replenish her fluid. Then you have to address the underlying infection that's causing her to go into toxic shock. The older adult diagnosed with heart failure tells the nurse he has not been feeling well for the past 2 weeks. Okay, that was interesting. It is most important for the nurse to ask which of the following questions. Do your ankles become swollen at the end of the day? Are you having trouble sleeping at night? How do you feel after dinner? Do you have chest pain when you inhale? No, they didn't. For some reason that comes up there. No. Okay, 33% said ankles swollen, 14% said trouble sleeping at night, 10% said how do you feel after dinner, 43% said chest pain when you inhale. Okay, so we have a patient with heart failure. Now, Marcia taught you all about heart failure, right? And she taught you that there's right-sided and left-sided heart failure, and you learned all of the, we're going to review that again this semester, just as a refresher, very quickly, not as long as she probably spent on it. But you know that you're going to have certain signs and symptoms based on whether it's right-sided heart failure, which for right-sided, what are you going to see? Edema. So peripheral stuff, right? Peripheral edema, JVD, hepatomegaly. So signs and symptoms of fluid overload into the peripheral circulation. If you have left-sided heart failure, what are you going to see? Pulmonary symptoms. So you're going to have crackles, indicative of fluid backing up into the pulmonary circulation. In your practice, what have you seen about most of your patients that have come in with a diagnosis of CHF? They have both, right? They have signs of both, because the most common cause of left-sided heart failure is right-sided heart failure, and vice versa. Once one side of the heart fails, the other side's not too far behind. So initially, that patient may show specific signs and symptoms based on one side of the heart. Patients with chronic CHF are going to have both signs. So that's going to help you prioritize in this particular question, because it doesn't say what side of the heart is having a problem, right? So let's take 3 and 4, because I'm going to tell you right now, the answer is either 1 or 2. Okay? 3, how do you feel after dinner? Is that going to tell you anything about their condition, whether they've deteriorated, decompensated? How about chest pain when you inhale? And that's one of those little buzzwords that everybody, chest pain, pain. Everybody wants to jump in on chest pain. But is your patient in congestive heart failure routinely going to have chest pain? No. Patients with coronary artery disease are going to have chest pain. A patient with a severe decompensation of their CHF, where their heart muscle is actually dying because of the, because it's failing, may have chest pain. And it also says chest pain when you inhale. If patients have chest pain related to coronary artery disease, does it get worse when they take a deep breath? No, chest pain when you inhale is indicative of a respiratory problem, primarily pulmonary embolus, not a coronary artery or a cardiovascular one, because if a patient's having coronary chest pain, they're going to have it regardless of whether they're inhaling or exhaling. It's just going to hurt all the time. So 3 and 4, we have to eliminate. So now we're looking at, do your ankles become swollen or are you having trouble sleeping at night? What does number 1 tell you? He's got right-sided heart failure, but again, we don't know that from the picture. But I would imagine that if you asked 100 patients that have a diagnosis of congestive heart failure, 99.9% of them would say, yeah, my ankles get swollen at the end of the day. Yeah, I mean, that's just, you know, they're peripheral circulatory, so they're having, you know, they're usually having peripheral edema. Most patients with congestive heart failure are going to have some peripheral edema. What is number 2? When you ask them, are you having trouble sleeping at night? What kind of information is that going to give you? Orthopnea. Because if the patient is having a decompensation of his congestive heart failure, and he's got left-sided failure, which, as we said, most patients have both-sided failure, they're having a backup of fluid into their lungs, and they're not able to sleep at night unless the head of the bed is up, or I've had patients that have said I have to sleep in the recliner, because if they lay flat, they can't breathe. So that's going to give you, and again, this is because it's an NCLEX question, it's probably not worded the way you would ask them. You would probably say, are you having trouble breathing at night? But that would give away the question, right? Because if I had worded it as, are you having trouble breathing at night? Would probably more of you pick that one, you think? Given what we've just talked about? Probably, maybe, hopefully. But are you having trouble sleeping at night is one of those backhanded ways on an NCLEX question of determining, is this patient having a respiratory issue based on a decompensation of their heart failure? So number 2 is the correct answer. It would, yeah, but primarily when you have a patient that's diagnosed with heart failure that's not been feeling well, so it's the fact that he hasn't been feeling well for a couple of weeks shows that he's going into a decompensation, because you've had, how many patients have you had admitted to the hospital with you know, an exacerbation of CHF? You know, the only other one that you see more frequently is the exacerbation of COPD. But that patient with an exacerbation of CHF, they either haven't been following their diet, or, you know, their heart is failing more and they're having more respiratory issues. They're not coming in, you know, most of the time because their ankles are getting swollen, because that's kind of like, that's their life. Their ankles are getting swollen. But if they're having trouble breathing at night when they're trying to sleep, or when they're really decompensated, they have that condition called paroxysmal nocturnal dyspnea, PND, where they wake up suddenly breathless. That's going to be, so this is one of those backhanded NCLEX style questions that says, okay, I got to look more into this, because those swollen ankles are almost too obvious, and where we're going to look for that. The nurse caring for clients in the oncology clinic gets 4 phone messages. Which should she call first? The client with leukemia receiving chemo complaining of fatigue and loss of appetite. The client with a mastectomy 2 weeks ago complaining of itching at the incision. The client with a new diagnosis of colon cancer saying that his stool specimen tested positive for blood. The client with lung cancer complaining of urinary incontinence and difficulty ambulating. Okay, 5% said leukemia, chemo, fatigue, loss of appetite. 19% said itching at a mastectomy incision. 33% said new diagnosis of colon cancer with a positive stool. And 43% said lung cancer, incontinence, and difficulty ambulating. So this is one of those where you can kind of use your, 3 are similar, pick the one that's different. Because 3 of these options are things that you would expect. They're routine. So number 1, you would expect that patient with chemo to have fatigue and loss of appetite. That's a common expected side effect of chemo. So that wouldn't be your priority person to call. The itching mastectomy incision, anybody who's had surgery knows that the incision itches a few weeks after the surgery. But the majority of you wanted either the number 3 or number 4. And what is it about number 3 that makes it wrong? That probably a lot of you jumped in on because it was a positive bloody stool, right? A stool positive for blood. You would expect that because if he's got a new diagnosis of colon cancer, probably one of the screening tools to find that let everybody know that he might have colon cancer was a positive stool for blood. So if he called and said he was, passing huge bloody clots, then you'd be concerned about him. But still not as concerned as number 4. Why? Not necessarily to the brain, to the spinal cord. Because if you're looking at, a lung cancer patient, normally what they're going to be complaining about, I'm having more difficulty breathing, I've got more of a cough, respiratory kinds of symptoms you would think you would have, you would expect. But you would not expect somebody with a cancer up here to be having troubles peeing and walking. But he's got a metastasis to the spinal cord that's pressing on those nerves that innervate the bladder, so it's making it hard for him to void, and innervating the legs, making it difficult. So that is an oncologic emergency called spinal cord compression, something you would not expect, although it is a very common end-stage complication of some types of cancers, including lung cancer. It's still an emergency that you would need to address before you would address the patient with the positive bloody stool. Delegation, we have 3 RNs, 1 LPN. We should consider the assignments appropriate if the LPN is assigned to care for which of the following patients? 6-month-old child with cleft lip repair yesterday, 2-year-old child just admitted with asthma, 6-year-old child with hernia repair yesterday, 10-year-old girl with Harrington rod insertion yesterday. Okay, so this is one of those questions where we have to look at, you've got 3 RNs and an LPN. They want to know who's the best patient to give to the LPN. So that means you're picking the patient that is the most stable and has the least potential for complications and risks. And some of the techniques and ways that you do that is to look at extremes of age. So the very young and the very old are going to have more potential for complications and risks. The proximity in time of when a procedure might have been done, so that if you had a patient that had surgery today versus somebody that had the same surgery a week ago, the person who had it today would obviously be at a higher risk for complications than the one who had it a week ago. So those are some of the techniques that you can use to determine acuity, which is going to help you on prioritization questions and also delegation questions. But we really don't have a whole lot. Everything's happened yesterday or just happened. So what we want to do is, again, we want to find out which of these patients is the least complex, least risk for problems. So, because that's the one we're going to give to the LPN. So we have 16% cleft lip repair yesterday, 11% 2-year-old admitted with asthma, 6-year-old with hernia repair got 53%, 10-year-old with Harrington rod insertion yesterday. So why would we say the 6-month-old is probably not safe to give to the LPN? too young, and something that had, potential for respiratory complications. Again, not to say an LPN it wouldn't be perfectly capable of taking care of that patient, but you have to look at it from purely NCLEX methods of delegation and prioritization. 2-year-old just admitted with asthma. You've got a potential, very high potential for risk with respiratory distress, and also just admitted, they need the admission assessment, has to be done by the RN. 6-year-old with hernia repair yesterday, 10-year-old with Harrington rod insertion yesterday. So they both had surgery yesterday. Does anybody know what a Harrington rod is? It's for scoliosis. But even if you didn't know that it was for scoliosis, it sounds pretty nasty. Somebody got a rod put into them somewhere. So that's a much more complex surgery, you could assume, if you didn't know about it, than somebody getting a hernia repair. Because most adults that have a hernia repair, it's one-day surgery and they're out the same day. They don't even stay overnight. Probably the only reason with a hernia that he stayed overnight because he was 6 years old. So the 6-year-old with the hernia repair yesterday has the least potential for complications. It's a less invasive surgery. It's not a big neurosurgical orthopedic kind of process that the Harrington rod is. So yes, the 6-year-old is the one that you could assign to the LPN, the least problems with complications. The nurse instructs the CNA to administer an enteral feeding via NG tube to a patient with dysphagia due to a CVA. Now they love to ask you questions like this because you read that first sentence and what's the first thing that you say to yourself? No, I would never do that. Because they want you to freak out. But the second sentence says, which of the following actions should the nurse take first? So get it out of your brain that they're wanting to know, that they're thinking or they're trying to tell you that it's okay to delegate that task to the CNA. They just want to know in this question, what are you going to do first? Instruct the nursing assistant to infuse the tube feeding slowly, place the patient in high Fowler's position, measure the pH of the gastric aspirate, obtain the patient's weight. What is the nurse going to do first? Okay, nobody wanted to instruct the nursing assistant to infuse the tube feeding slowly. Thank you, God. 57% said place the patient in high Fowler's, 33% said measure the pH, and 10% said obtain the weight. So obtaining the patient's weight, not a priority at this point. It's part of the plan of care again. Place the client in high Fowler's, measure the pH of the gastric aspirate. Actually, number 3 is the correct answer. We need to check the placement of the tube before we do anything. We're not going to reposition the patient. We're not going to do anything until we know that the tube is where it should be. Now, the most accurate way of assessing NG tube placement is measuring the pH. That's not something that you see nurses do on a regular basis. But again, that's textbook, the best way to ensure that it's actually in the stomach. Most of us, inject air, listen for the bubble, withdraw for residual, those kinds of things. But there's not a lot of us walking around with the litmus papers testing the acidity of the pH, of the gastric aspirate. But that is the most accurate way. So that is the first thing that you're going to do before you reposition the patient, and definitely long before you would ever tell a CNA to infuse it slowly. That's our last question. You want a little information about the exam. I don't know if Joan told you anything about the psych exam. A little bit. It's 125 questions. I'm just going to stop the recording here.